for both pain and function, okay, are anticipated to outweigh the risk to the patient. You will not, especially neuropathic pain or radicular pain, nerve pain. Opioids don't help, okay? They will stop breathing and die with nerve pain if you only treat it with an opioid. It merely helps you not care about the pain, but the pain is still there, okay? So we have to look at function, not necessarily pain. Is you know, grandma, sorry, but my mom, she's not an opioid, but nonetheless, is she more functional? Can she get up and take care of her activities of daily living? If she needs a Norco to do that, okay, there's no problem, right? If opioids are used, they should be combined with non-pharmacological therapy and non-opioid pharmacological therapy as appropriate. Doc, my back hurts. Okay, let's try Tylenol. Let's try Advil. Let's try Tylenol number 3 with codeine. Start small. Give yourself some room, okay? It might go away within 3 months. Most of it does, all right? But don't start in with dilaudid 4 milligrams Q8 or Q, 4. And I have patients in California that have come in on this. I'm like, oh, okay, so there's nowhere to go, right? Opioids are not first-line or routine therapy for chronic pain. Non-pharmacological therapy such as exercise, cognitive behavioral therapy to reduce pain and improve function, which is what we need to pay attention to. Use of non-opioid pharmacological therapies, NSAIDs, Tylenol, anticonvulsants such as gabapentin, okay? Certain antidepressants, when benefits outweigh the risk, combined with non-pharmacological therapy, physical therapy. When opioids are used combined with non-pharmacological therapy and non-opioid therapy to provide greater benefits. So what that's saying is start low. Start Advil, gabapentin, physical therapy, come back in a month. That buys you time. You're doing something. Let's buy time. Did it work? Doc, I felt a little better. Great, right? No, it didn't work. Okay, step 2, we might entertain an opioid. Small, tramadol, Tylenol 3, Tylenol 4, and then maybe Norco. That's all in the handout too, how to go step by step. Okay, recommendation number 2. Before starting opioid therapy for chronic pain, clinicians should establish treatment goals with all patients, including realistic goals for pain and function, and should consider how therapy will be discontinued if the benefits do not outweigh the risk. All right? Therapy goal sheet, that should be in the handout. Clinicians should continue opioid therapy only if there is clinical meaningful improvement in pain and function that outweighs the risk to patient safety. Doc, it didn't work. I'm on hydrocodone 5, 3 times a day. Didn't work. Okay. Let's go to hydrocodone 10, 3 times a day. Doc, no change. I'm like, really? Okay, then let's stop it. It didn't work, then let's stop it. All right? It's not working. Why do it? Why take it? Well, it's working a little bit. Okay. Then we're going to let it work a little bit, right? It's not. Pain-free is not our goal, okay? Our goal is better function. We don't get to be 18 again. Sorry. I want to be 18 again too. But learning to cope with pain and integrate it into your activity daily living in your life, right? Cope with it. Establish and measure these goals, the progress toward the goals. Before initiating the therapy, determine how the effectiveness will be evaluated. Establish treatment goals, pain relief. Are we going to say 50% reduction and then we're happy? Or 0%? 0% won't happen. Maybe it will. Or 0 pain. But 50% pain reduction, I think we're doing pretty good. I think we're doing pretty good. Let's stop right there with the opioids. It's 5, 10, 3 times a day, whatever. and function. Assess the progress using the 3-item PEG assessment scale. That is in the handout. I use the BPI, basic pain index, which uses function and antidepressant scale or depression scale to help. It's just a little bit more detailed than this 3-item PEG scale, but that's in the handout, and these things you can measure. So they recommend 30% equals clinically, 30% equals clinically meaningful improvement. So 100% is not the goal, right? We got 30%, I think we're doing okay. Hold it down, downward pressure. You're not, one more pill does not make better sometimes, right? All right, so recommendation number 3. Before starting and periodically during opioid therapy, clinicians should discuss with patients the known risk and realistic benefits of opioid therapy and the patient and clinician responsibility for managing the therapy. I have an opioid risk tool, and if that's not in the handout, I can get it. Prior to starting an opioid, assess their risk. One of the risks is, do you have a history of opioid abuse, right? Well, this might not be the best thing, right? So let's not do it. If you have a history of heroin addiction, let's say, or even any addiction such as methamphetamines, heroin, cocaine, these hard street drugs. Maybe not the best candidates to start on opioids. Childhood abuse is on there, actually. Sexual abuse is on there. The opioid can't cure emotional pain, which emotional pain is real. It's real. It can cause somatic pain. But opioid is not the right medication or approach to that sort of pain. So opioid risk tool, and that if it's not provided, I can certainly provide it. Okay, I didn't have a chance to look at over the handout.
That one's not in there. We'll
Okay,
get it.
so I'll be up. Ensure patients are aware of potential benefits, harms, and alternatives. Be explicit. Be realistic about expected benefits. 100% is not my goal. Sorry. We have to worry about function. Emphasize the goal of improvement in pain and function. Just make sure you discuss the serious and common side effects, adverse effects. One that I'd like to point out is constipation. That in an older person is no small thing, okay? They can get constipated and perf a bowel and die. So always ask about constipation. It was a board question, actually. If they're not complaining of constipation, chances are they're selling or diverting their opioid. Mm. I was like, I disagree. We test everybody, that comes in urine drug screens. Not everybody gets it. I don't know why, but they still take their meds. But it is something to think about, especially in a young, active person. No constipation, really? Okay. So are you really taking it? Screen. Increased risk of overdoses at higher dosages, and when opioids are taken with other drugs, alcohol. An alcoholic probably wouldn't be the best candidate either. Periodic reassessment, checking the PMP, in the California's PDMP, and urine drug screens, and the risk to the family members and individuals in the community. I know that you love your kids, and they're good kids, and they get straight A's, but they're 15 or 16. Lock those opioids up. Mm-hmm. You don't want them to take that risk. You trust them, they're good people, honestly, but they're 15 and 16, and they will try, okay? So you lock them up. Keep them out of their reach so they don't try. Patients, I had a party at my house, and I go to my drug cabinet, and all of my medications are gone. I had just had my best friends there. Best friends raiding their medicine cabinets. Okay. So that's risk to the community. Always assess. You're managing pain, so you've got to pay attention and manage the opioid for not only for the patient but for the community as a whole. I'd like to take this second to say one of the questions in California was, well, is Chico, we're way out of the range. We have a big drug problem in Chico, California. I'm like, no, you really don't. It's any city, USA. It's across the board. Roswell has a drug problem. No, it's any city across the board. It's no worse here than it is in any city. And this is true, okay? We live here and we think it's bad because we see it, but it's any city. This is nationwide, okay? Recommendation 4. When starting opioid therapy for chronic pain, clinicians should prescribe the immediate release, and this is key, okay? The immediate release opioids instead of the extended release, okay? Extended release opioids on their face, now extended releases opioids are less addictive, okay? Because the patient doesn't really notice the onset and the offset. They don't get an immediate high and then a loss, okay? So longer acting opioids are less addictive, i.e. methadone, right? Methadone is used for heroin addicts because of its long duration. It's still an opioid, just like heroin. Heroin's pharmacological profile goes straight up and straight down, which makes it very addictive. And when you reach those peaks is when you stop breathing and die. Methadone is more smooth, so it's less addictive, but that is the wrong thing, okay, for treatment especially in the primary care environment. I take the long acting. I'm not really feeling immediate, relief. I should take another one, and then I'm gonna go to bed. I'm gonna take a couple beers like I normally do, or a glass of wine, then I'm gonna go to bed. And in their sleep, they overdose. They stop breathing and die. There's no second chance, okay? And so you want a shorter acting one so those opioids have a chance of wearing off, okay? As a corollary to that, it used to be taught that you should take it in anticipation of the pain, right? Take it before it hurts. No, right? Wait until it hurts to take it. Because if you take it by the clock, every 6 hours, your body doesn't know if it's hurting or not. It just is used to a constant level of opioid. And over time, it stops working. It becomes background. And then they need more to cover it when they hurt. Pain waxes and wanes during the day. Wait until you go, oh, it hurts, and then take it. And then you know it works, okay? You're reassured and you're decreasing your exposure, your body's exposure to the opioid, your patient's body, all right? Choose predictable pharmacokinetics and pharmacodynamics to minimize overdose risk. In general, avoid the use of immediate release opioids in combination with the long-acting. When you get to that point, you really should just get them to a pain specialist, because I would say, oh, you've been on a short-acting for some time. I would make a calculation which is provided in there, and I can reduce the opioid level by a long-term, give you the background, and then give you another short-term for pain breakouts. But not in a primary care setting, because we're dealing with hopefully immediate acute pain or pain lasting less than 3 months. Okay. So methadone has many advantages, but should not be the first choice. Okay. It has unique risks, which are prepared, unique risk, and who are prepared to educate and closely monitor their patients should consider prescribing it for pain. It stacks, it builds up in the system, so you can get a relative overdose later. This is a good one. Only consider prescribing transdermal fentanyl if familiar with the dosing and absorption properties and prepared to educate patients about its use. Transdermal fentanyl should come off the market. And I have a slide in here about Soma as well, okay? Transdermal fentanyl, what is happening, 25 mics of fentanyl, and that's a small patch. I mean, this is a little bit, right? It's 25 mics. But it's given 25 mics an hour over 3 days. That's the actual amount, right? So if you melt this down and inject, you're getting I can't come up with the number, it's something to the effect of 2,000 or 1,800 grams or milligrams of fentanyl, which is equivalent to, I think, 100 grams of morphine or something, 100 milligrams of morphine. It's a phenomenal dose. And you hear about these heroin addicts that are overdosing because they're mixing it with fentanyl. Fentanyl is 100 times stronger than morphine. So it's an enormous dose of opioids in this one small 25 mic patch. They should come off the market. That's one. Two is fentanyl is not only a very strong opioid, but it is the first to obtain. I just have lost my train of thought. Tolerance to. Okay. So you take if you gave fentanyl, they would become more tolerant to the fentanyl than they would morphine. So it stops working faster than regular old morphine. So you go up and up and up, and now it's only working, the doc, it only works 2 days, not 3. So you prescribe it every 2 days. Wrong. As long as they're still able to use their mouth, right, it is better to go through the gut and use a pill. It's abuse deterrent. It's really not. It creates more addiction or tolerance, dependence. Okay, and we can talk about the definition of that, but we're going through recommendations. Recommendation number 5. When opioids are started, clinicians should prescribe the lowest effective dose. Clinicians should use caution when prescribing opioids at any dosage. Should carefully reassess evidence of individual benefits and risk when increasing the dose to greater than 50 morphine milligrams equivalent. They're using morphine milligrams equivalent to standardize the dosage between the opioids. Is it a real equivalent dosage? It's really not. Okay. Different people metabolize medications differently depending on their genetics. We can test that now, and I did for a while, but the test disappeared. But you can test their genetics and their metabolism, how it goes through the P450 enzymes in the liver. And some people do have different metabolisms, but this is a good starting point. Milligrams of morphine. That conversion is in your handout. To give you an idea, oxycodone is 2.5 milligram equivalent of morphine. So you're taking 50, let's say you're on oxycodone 3 times a day. That is 30 milligrams in 24 hours of oxycodone times 2.5, that's 110, is that right?
No.
It's 30 times 2 is 60,
60.
plus 50, 75.
Half of that.
It's 75, you're right. So you're 3 times a day is 75 milligrams of morphine equivalent. You're already above your 50 milligram per day equivalent. So that's a high dose, guys. 100, I used 100 my entire practice. They say 90. That's okay. Greater than 90 is a high dose. So 4 times a day is a high dose. That's more than 90, okay? That's just to give you relative opioid strength, okay? So
that is listed on the PMP too.
the 2.5?
No, just they will tell you what the total
milligrams.
amount.
Yes, it is, and they do track it now. I looked at the tracking, yeah. And so, just to give you an idea, this is the recommendation. Okay, this is the key. This is the big point here. 50 is a good dose. 90, greater than 90, is high dose. Okay. Discuss other pain therapies with the patient. Consider working with the patient to taper down or off the opioids. Sir, you're on 5,000 milligrams of morphine equivalent a day. 5,000 in California. I almost came out of my chair. Wow, that's a record. But you're sitting here in front of me saying you hurt. I believe them. They believe that they hurt, and they probably do, right? But 5,000 it's not working. It's time to come off. And I did. I tapered them down, and now they're on maybe 5 milligrams of hydrocodone a day. At some point, it doesn't work. So stop and go, well, it's not working, we're coming off. And you'll either get, well, it's working a little bit, okay, then we're stopping. Or, yeah, it's not working, I'll come off of it. And you'll be surprised how many of them want to come off. It's only 5% that actually end up being actually addicted. That's nationwide, 5 to 8%. And I see that in my practice. So, patients already receiving a high dose, okay? Offer to establish patients already taking greater than 90 milligrams morphine equivalent per day the opportunity to reevaluate their continued use of high-dose opioids in light of the recent evidence regarding the risk of associated opioid dosage and overdose risk. Discuss the possibility of OIH, okay, opioid-induced hyperalgesia, and I put a slide in here about that to help us kind of ferret that out. And for patients who agree to taper their opioids, which will be more than you think, okay? When I started pain medicine, it was just all of my patients were addicts, and I'm the drug dealer. That is not the case, okay? Most of them don't want to take it because of all the side effects, the constipation, the drowsiness, the low function. They want to try something else. If you can do a procedure and get rid of their pain, you would be shocked how fast they come off those opioids. I've been doing this for 15 years, and I am still shocked. Pain's better, stop the opioids. Waldo's here, this is my plug. For the spinal cord stimulator. Spinal cord stimulators for neuropathic pain, radicular pain, does not respond to opioids. They're on enormous doses of opioids. The only reason they're not dead is because they still hurt, and that keeps them breathing through the night. You put in a stimulator that does affect the neurologic pain, they go, I don't need it. I have patients on enormous doses and stopped it overnight. They stopped it so fast, one of them, he stopped his benzos, which we'll get to, and it actually killed him. He was pain better, and he was ready to go back to work. He was a cop. And he was so excited that his pain was better.
I've got a question on that slide. You
Yes.
talked about, you contract with the patient, you recommend they quit. The last one, for those who agree to taper, what do you do with ones who say, hell no, it hurts too much when I miss a dose?
Right, well, you're on a high dose. And you say, okay, it's time to taper. No, right? No way. One, there might be a psychological component to it. It's like a safety blanket. You know, you have your blankie, and you don't want to let go of it. And so there's a psychological component that you say, okay, we're going to work together to slowly take your blankie away, okay? You don't stress them because there's anxiety there. That's real. If I hurt that bad, I've had a kidney stone, right? I mean, it hurts. You don't want to hurt like that again. So you hold on to this med, okay? But the pain is not working. Let's slowly back down. You slowly back down. And it's almost a counseling session. A lot of it is psychosocial that I do. My nurse practitioner quit today, and I'm on the way driving here, and I'm thinking, who would be ideal to replace her? And a thought came through that it should be a therapist, someone who can sit and listen and help develop coping strategies with the pain and coax them off their opioids. I do that. That's what I do. I sit and I talk to them and I coax them down. That's it.
Yeah. We had a provider here for a month or two who would either just cut the dose in half immediately, or at times played games where she just stopped it and refused to fill it. And that really messed with some people's lives.
Right.
And yet, you know, a lot of times I find if they're thinking 6 a day, and
Yeah.
we say, let's do 5.
Right?
So, you know, and maybe I'll tell them in the next 3 months, we're gonna have to talk about some drops.
Right.
These are some things we're gonna try. I'm not even gonna drop you right now, but I want you to start trying to go without sometimes, drop your dose one day. Maybe one day you do 5, the next day you do 6.
Right.
You know, you can get them ready for it. We don't want to freak out and
I agree 100%. Yes.
destroy your life.
Yeah, yes. And so I go, okay, you're taking 6. We're going to taper, not now. Not gonna, I want you to do this, which is important. You put the patient in control of their pain. They're in control. So that is important to them. And it's important to the treating pain that they are in control of their pain. It's not, I'm coming down from above and we're taking them away. That creates anxiety, depression, which makes the pain worse, okay? And so you say, we are, per this recommendations, gonna establish goals. In 6 months, would it be reasonable to go from 6 to 4? In 6 months? Yes. Yeah, that's perfectly reasonable. This is a marathon, it's not a sprint. This chronic pain, you have this, a goal, right? So how do you do that, right? I want you to go to take, I go, listen, you're taking 6. Let's try, cut it in half, and let's go for 5 1/2. I don't care which one you cut in half, I don't care. Find one, cut it, find one of those dosages, and cut it in half. See, if you're coming to me next month, and you say, Doc, I'm gonna take 5 1/2, I'm still gonna give you your 6. I'm not gonna take them away, because I'm still gonna give you your 6. But 5 1/2, we have made progress. Patients respond, actually, and feel good about themselves, and they're in more of control of their pain and their dosing schedule, okay? So 2 months later, a whole pill a day. That is progress, that's big progress. You've taken 30 pills off the street, right? And patients are feeling good, they're on board. They're like, yeah, I can do this. Yes, you can. I rarely cut them down. I tell them, I want you to come to me next time, and this is our goal, and you let me know how it goes. Doc, I wasn't able to do it, right? That's okay. We're gonna try again. We all talk about smoking, right? That's how you do smoking. You try, you fail, you try again. Don't come down on yourself. You're not a bad person. You're not weak. We're gonna try this together. And they respond. They do. Okay? I'm telling you, only 5% abuse or are addicted, and those patients, they're easily ferreted out. I mean, you can tell an abusive behavior. Okay? So this is a good slide. Opioid-induced hyperalgesia, OIH. I recognize this through practice over 15 years. Now we have proof. Long-term high-dose opioids can cause pain, right? Rather than relief pain. But what were the symptoms? Here in a moment. The medicine causes the pain. Not that you're tolerant or all these things. The medicine causes the pain. I have seen this many times. They go, symptoms. Increased sensitivity to painful or non-painful stimuli. Does this hurt? I'm like, really? That hurts. I mean, okay. I'm like, wow, okay, wow. I believe them. I can't assess their pain, right? Okay, fine. Well, that's a pretty strong result to a small stimulus. Okay, fine. No worsening pain despite worsening pain despite increased opioid doses. So if you go up, doc, it's getting worse. Your immediate response is, well, we need more. No, maybe we need less, okay? They decrease the pain threshold, so maybe they're to the point where that is hurtful. Fibromyalgia, hurt everywhere. It's the opioid, okay? Pain that becomes, this is important, pain that becomes more spread out, extending beyond the area of the usual pain, especially nerve pain, has tracks. One of my things is, I come in the room, I review the MRIs, CT scan, whatever, before I come in, and their, body, form that they fill in where it hurts and all this stuff. I read all of it. And then I go, okay, I've read all this, but I want to ask you, where does it hurt? Well, doc, I hurt all over. Okay, that's fine. You can hurt all over. But what one gets in the way the most? Okay, well, I guess it's my back. I make them point to it. Here. Where does it go? Well, it goes right through here into my big toe. That's a definite radicular. You can point, okay? It's not that it wraps my whole leg hurts. That's not radicular. I mean, that's just not a radicular pattern. That matches their MRI. I hurt all over, everything hurts. Well, you're on 200 milligrams of morphine a day and everything still hurts. Okay, I want to introduce opioid-induced hyperalgesia. It's the opioid. I get them to stop. I'm still shocked that I'm able to do it, but it takes listening and coaxing. Patients stop, they come in, their eyes are this big. Doc, I don't hurt, and I don't take my pain meds. Doc, I don't have pain, and I don't take my pain meds. It was the pain med that was causing the pain. They can't make heads or tails of it, but I have had this happen many times, okay? So one of the things, we go up, not helping, okay, then let's stop. It adds to your confidence that that might be the right clinical judgment, okay? Opioid-induced hyperalgesia. How is opioid-induced hyperalgesia different than tolerance, okay? So, increasing the dosage of opioids can be an effective way to overcome tolerance if the pain is relieved with opioid medication. You come in at 3 times a day? Okay, I'm going to double it. I've doubled it. I'm going to 10 3 times a day. You're still within the range, okay? You're still low. That's why you start low. You double it. Okay, now it's better. Okay, maybe it was tolerance, maybe. In OIH, increased medication, I doubled it. Doc, it seemed like it got worse. Maybe it's time to stop. Opioid-induced hyperalgesia, okay? That adds to your confidence that maybe the right thing is to come off of it, okay? We can talk about, I think I skipped that part, but in the talk, we can talk about how they're metabolized through the liver and different mechanisms that you can look at. I think that's a little bit too detailed for this talk, but I'm happy to do it at another time. All right, so recommendation number 6. Long-term opioid use often begins with treatment of acute pain. When opioids are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release opioids and should prescribe no greater than the quantity needed for the expected duration of pain, okay? Severe enough to require opioids. So lots in that sentence, we'll get to it. 3 days or less will often be sufficient. More than 7 will rarely be needed. So acute low back pain,